This conference will now be recorded.
So today we are going to discuss this October 2020 talk, that is multifetal pregnancy reduction and selective termination. So this two are different terminologies. We will come to that. What is multifetal pregnancy reduction and what do you mean by selective termination? So actually these two are different terminologies, and we should see what are the methods to do this fetal reduction and selective termination gestational age wise. Okay, so this is the basically covered in the talk and what are the risks associated with it. So regarding multifetal pregnancy, basically the major cause of increase in the rate of multifetal pregnancy nowadays is because of artificial reproductive techniques, because the number of embryos transferred, okay, because of multiple embryo transfer like 2 or 3, it will increase the multiple pregnancy, and it is the single biggest contributor to multiple pregnancy. So following IVF conception, 1 in 5 birth, it results in multiple pregnancy. Also, along with this higher increase in this dichorionic twinning pregnancy, IVF also doubles the risk of monozygosity, okay? As compared to the natural conception, IVF increases the risk of this monochorionic pregnancy also. When basically when you do late blastocyst transfer, okay? So this late blastocyst transfer, it increases the chances of monochorionic diamniotic MCDA twins. And the major drawback associated with this multiple pregnancy is the preterm birth, and this preterm birth which is responsible for this major neurological morbidity, that is cerebral palsy. Okay, so if you see the cerebral palsy incidence according to the multiple pregnancy order, so in singleton pregnancy, cerebral palsy incidence is around 1 in 400 babies or 1 in 400 fetuses. Twins, it reduced to 1 in 100 fetuses, and in triplets it's further reduced to 1 in 30 fetus. See, it is 1 in 30 fetus or approximately 1 in 12 pregnancies incidence of cerebral palsy. In quadruplet pregnancy, 1 fetus in 10 babies. Okay, so 1 fetus in 10, so it is 4 in 10 pregnancies. And in higher order pregnancy, it is almost 1 in 2 pregnancies. So the chance of incidence of cerebral palsy, it increases with the increasing multiple pregnancy order. So basically, to reduce this incidence, actually it is legal to do the selective termination in case of multiple pregnancies. So what are the grounds which are used for this abortion clause, as you are aware of? So multiple pregnancies in case of anomalous baby. So in case of multiple pregnancy with one anomalous baby, selective termination comes under ground E. Also, when the multiple pregnancy order is more than 3, that is quadruplet and above. So in quadruplet and above pregnancies, selective fetal reduction. See, fetal reduction means normal embryo reduction, okay? Normal sac reduction. So when the baby is normal, it is called as fetal reduction, while selective termination is the termination of the anomalous baby of one of the multiple pregnancies, okay? So selective termination and quadruple pregnancies and above reduction, fetal reduction, it comes under ground E, because there is a unacceptable risk to the preterm birth related disability, okay? Serious developmental abnormality or serious disability to the upcoming fetus, okay? So it is a clause E which is used, so it can be done at any gestation, okay? So the difference between this thing and this ground C is that, so selective termination for anomaly and fetal reduction for quadruplet and more, it becomes ground E, so you can terminate at any gestation. And in twins and triplet, the risk of preterm and that neurodevelopment anomaly is risk is smaller. So here, the selective termination or fetal reduction, it comes under ground C. So here you have to do it before 24 weeks. Okay. So in the underground C, you have to terminate before 24 weeks, while in case of ground E, you can terminate at any gestation. So this is the basic difference between these two grounds. Okay. Then next thing here is, yes, yeah.
Selective termination only for anomalous baby, or
Yes.
or for the high? Can you please explain that? Sorry, I couldn't understand that part.
See here. See, the selective termination is termination of abnormal fetus. It is called as selective termination. Okay. And termination of one or more normal embryos in higher order pregnancy, it is called as multifetal pregnancy reduction. So quadruplet and higher order multifetal termination, multifetal reduction. Okay. Sorry. So you want to know regarding this slide, no? Correct, regarding the
Ma'am,
grounds. Correct?
yes, ground. Yes, yes.
So quadruplet and above, multiple fetal reduction. Okay. It is called as fetal reduction only. It is not selective termination. Got it? So selective
Yes,
termination for anomalous baby, whether it is in case of twins, triplets, or whatever. Okay. Twins, triplets, or whatever, for anomalous baby, if you are doing selective termination, or quadruplets and more, you are doing multifetal reduction. This comes under ground E. Got it? While in case
yes,
of twins
ma'am.
and triplets, when you are doing multifetal reduction, okay, actually they have used here the word selective termination. In talk also they have used this word selective termination, but it is not appropriate word. But so in case of twins and triplets, when you are doing multifetal reduction, it comes under ground C. Got it? Am I clear?
Yes, ma'am. Thank you. Yes.
Yeah. So termination of abnormal fetus, it is known as selective termination, and termination of one or more normal embryos in case of higher order multifetal pregnancy, it is known as multifetal pregnancy reduction. Got it? So prerequisites for this multifetal reduction or selective termination. So basically the woman should have timely access to the appropriate regulated service. So appropriate regulated service here in case it is the fetal medicine. Okay. So they should have this timely access to the antenatal services and fetal medicine services regarding discussion of these options. And this ST and MFPR, both it should be done in tertiary level fetal medicine service. Okay, because it is associated with so many, just not physical complications to the mother, baby, and also psychological consequences. So it should be done in the tertiary level fetal medicine services. Here, before you want to do any decide regarding any MFPR or any selective termination, the number of fetus and their chorionicity, it should be documented before 14 weeks to be certain. And whenever a doubt, as according to the monochorionic twin GTG, that second opinion should be taken of fetal medicine and the prints or photocopies should be preserved. Okay. So the fetuses and chorionicity, it should be determined before 14 weeks of gestation. Correct labeling of each fetus and their position, size, chorionicity, placental location, it should be done very meticulously to identify the correct fetus. Okay. Now, the women who are pregnant with triplet and higher order pregnancies, triplet and higher order, they should have been given option of this MFPR in the first trimester itself. So the MFPR should be discussed in first trimester so that we can be referred to the fetal medicine service between 11 to 14 weeks of gestation. Because if you do this MFPR after 16 weeks of gestation, there is more risk of all these other twins or other babies' death and all preterm deliveries. So the risk increases after 16 weeks. So for any higher order multiple pregnancy, you should give the option of this fetal reduction in the first trimester itself so that she can be referred to the fetal medicine services between 11 to 14 weeks of gestation. Now, whenever fetal abnormality is detected in case of multiple pregnancies, then she should be referred to the tertiary fetal medicine center and the referral time should be within 5 days. Got it? So any fetal abnormality in case of multiple pregnancy, they should be referred to the tertiary fetal medicine center and the referral time is within 5 days. And then for the selective termination, as I told you, for these clauses E and C, always there will be these two forms should be completed, that is HSA1 and HSA4. Okay. So these two forms should be completed. This can be a clinical governance question. So that's why I have highlighted this. Okay. Because there are new clinical governance questions are upcoming in each year exam. Okay. And those are usually, they are not previously repeated. So whenever there comes the question, whenever there comes an issue of clinical governance in any new talk or anything somewhere, you should be very much aware of that because that can be asked as a question. Now, what are the procedures which are for the fetuses which are having independent chorionicity. So when the chorionicity is independent, like DCDA or trichorionic diamniotic triplets. So whenever the chorionicity is independent, the method of choice for selective termination or multiple fetal reduction, whatever it is, the choice is direct intracardiac injection of potassium chloride. Okay, and it is performed as an OPD procedure under local anesthesia. So whenever you are going to do MFTRC, the anomaly you cannot identify at the age of 11 to 14 weeks unless it is a very severe anomaly, correct? But yes, MFTR, whenever you want to perform, it should be done optimally between 11 to 14 weeks of gestation. So now what is the procedure for this intracardiac KCL injection is 22 or 20 gauze needle, amniocentesis needle. It is advanced in the amniotic cavity and directly into the fetal heart, from which 0.5 to 2 ml of 15% KCL is injected until fetal asystole is confirmed. Okay. And now which baby you want to reduce, okay, which embryo you will be reducing. So it depends upon the ultrasound appearance and position. So if you find any abnormal or any suspicious finding in ultrasound, like increased NT or any other placental thickness, so anything suspicious if you find in one baby, better to terminate that embryo. Okay, and if there are no abnormalities are found on the ultrasound, then the embryos which are most technically accessible and farthest away from the cervix, they should be selected for reduction. Okay. So which embryo you want to select this, it depends upon the ultrasound feature and technical accessibility. Now when the selective
Excuse me,
reduction,
ma'am. Why?
yes,
Excuse me, ma'am.
yeah.
Why farthest away from cervix? Shouldn't it be the other way around? Matlab, I have no idea. I'm just thinking that.
See, now
Shouldn't
here you are not doing via this thing. It is usually it is a trans-abdominal, okay, amniocentesis, because 11 to 14 weeks it might be, it is a mostly trans-abdominal. So if
Okay,
you
got
do
it.
near the cervix, it will be very difficult technically. Okay. So when you do at the fundal level, it will be easy for you to inject. Got it?
Understood,
When
ma'am.
you are doing
Understood.
it trans-abdominally. Yeah.
Yes, yes.
Now,
Thank you.
when selective termination is performed for fetal abnormality during first trimester, like when you will be doing this selective termination for abnormality in first trimester, mostly because of aneuploidies or serious anomalies like anencephaly, sometimes you may diagnose before 14 weeks, correct? So in that case, great care should be taken throughout the procedure to correctly identify the affected embryo. Here it is important in case of selective termination. See, for multifetal reduction, you can reduce any baby, any embryo. But for selective termination, it is very important that you should correctly identify that abnormal fetus. So in that case, when basically you are doing it because of the CVS aneuploidy results. So you have done CVS, chorionic villus sampling, and you find out aneuploid fetus, and you are doing selective termination for that reason, then better the care should be taken to minimize the time interval between the CVS and subsequent selective termination. And the uh, same operator should be performing these both procedures so that he will aware regarding the position of the fetuses and all these things. And so the position of fetus will remain constant. Okay, the labeling of the fetus will be correct in that case. Now, when the chorionicity is independent, now one thing is there. In case of first trimester, you are going to inject direct intracardiac KCL injection. Now, what they are telling, in case of independent chorionicity, you should not do second trimester termination. Okay. Why? Because there is increased risk of preterm and major miscarriage. Okay. So, whenever you are finding any abnormality, okay, any abnormality after 16 weeks of gestation, fetal anomaly after 16 weeks of gestation, in case of independent chorionicity, the safe alternative for selective termination is again administer intracardiac KCL at 32 weeks and not before that. Why? Because if you inject that KCL at around 32 weeks, because of there is whenever you will inject in second trimester or third trimester, there is a high risk of preterm birth. So if you do it at so no. So whenever you do it at around 32 weeks, even if she undergoes preterm labor, the baby will be viable. Okay, the survival chances will be more with that fetus. Okay, and there is a risk of miscarriage and major disability will be very less. Mid pregnancy between 16 to 30 32 weeks of selective termination, it is associated with higher rate of pregnancy loss, severe preterm birth, and consequent neonatal morbidity and disability. Okay, so to avoid, basically you are doing this to avoid any this thing neurological abnormality. So better to do it at around 32 weeks. So even if the baby is born preterm, the neurodevelopmental disability risk will be reduced. So at 32 weeks of gestation, first you have to give prophylactic steroids, and then this intracardiac KCL injection, it should be given. It is around 5 to 10 ml. So here see, the volume of this KCL injection is more. Here for first trimester it is only 0.5 to 2 ml, but third trimester it becomes 5 to 10 ml of KCL or 10 to 30 ml of lignocaine with 20 gauge amniocentesis needle. Now again, to avoid terminating wrong fetus, you should not give injection in the cord. Okay, so intravascular administration of KCL via cordocentesis, it should be avoided. In cases in which ST is performed for chromosomal or genetical abnormality, diagnosed much earlier. Okay, so if you find some abnormality in quadruple markers at around 16 or 18 weeks, and when you are delaying that selective termination up to 32 weeks, it is better to repeat confirmatory amniocentesis shortly before this ST procedure. Okay, so just to confirm which baby. Okay, so better to confirm which baby is having this aneuploidy or any genetic abnormality before doing this feticide. While waiting for planned procedure, so when you are waiting for the selective termination at 32 weeks, there is risk that the baby may deliver preterm before 32 weeks of gestation because of multiple pregnancy. So again, it will lead to undesirable live birth of the affected twin. So in that case, the pregnancies, they should be closely monitored, and selective termination should be expedited if the preterm labor becomes imminent. Okay, so if the patient undergoes preterm labor at around 28 weeks and if the birth is imminent, better to do selective termination just before she goes in the established preterm. Okay, so that you can avoid the birth of that affected baby.
Excuse me, ma'am.
Yes. Yes.
You know, in the last paragraph, you said before 32 weeks, affected baby will be born, but we have terminated the affected baby, no?
No. When you are not going to terminate before 32 weeks.
Yes, it's whether it's we're going to terminate affected baby at 32 weeks. But
Yeah.
we are talking about birth of the unaffected baby at 32.
Yes. So see
I
here,
didn't-
does this, I
Yeah,
got
this
it, your
paragraph.
doubt. I got your doubt. Yeah. So see, before 32 weeks also there is risk of preterm labor for twins and multiple pregnancies, correct? So you are awaiting for this selective termination at 32 weeks. You have decided that procedure you should do at 32 weeks, okay? But unfortunately, that patient goes in labor at 28-29 weeks. So here you have not done termination yet. Selective termination you have not done yet. Okay, so in
Right.
that case, what you are going to do? So here you are going to monitor, and if the preterm labor becomes imminent, you are going to do this termination just before that preterm labor, so that that unaffected baby will not be born. Okay.
Okay. Got it. Thank you. Yeah.
Yes.
Excuse me, ma'am. Does this depend on the degree of anomaly? Because suppose delivery is anyway imminent, say at around 29 weeks, patient has gone into preterm labor. So, are we very sure, like, that this baby should not be born alive? Does it depend on the degree of anomaly, or it is the woman's choice which has to
It
be
is,
this way?
see, most of the time it is, see, in UK it is a woman's choice. See, in India that MPT laws are totally different. Okay, for non-lethal anomalies you are not going to do after 24 weeks or 20 weeks, correct? But there the laws are totally different. If the patient doesn't want that Down syndrome baby to be born, any aneuploid baby to be born, okay, they can do it. So for anomaly, as I told you, for any anomaly they can undergo termination at any gestational age. Got it?
Got it,
So
ma'am.
it
Thank you.
depends upon the woman's choice. It is not doctor's choice. But she may wish to have that Downs baby also intact. Okay, she may not want to terminate that Downs baby. So it is always woman's decision after giving careful choices to her. Okay, so she may not be wanting that termination at all also. So it depends upon the counseling and wishes of the patient. Got it? But if
Got
you
it.
want to do it, you should do it. Okay. So if you have decided termination at 32 weeks, if you have already, the birth plan will be there. So in UK, for everyone, birth plan will be there. So if that termination as ST has been decided at 32 weeks and she has gone in labor at 20 to 29 weeks, you should do the selective termination just before that preterm labor. Got it? Now, yes. So now till now we
Yes.
have seen this independent chorionicity. Now what happens for this monochorionic fetuses? So when the selective termination or multifetal reduction, it is performed for monochorionic pregnancy, this chemical feticide should not be done. It must be avoided. Remember, so intracardiac ACL is not an option for monochorionic pregnancies. Okay. So what are the techniques? So these are the modern vaso-occlusive techniques. They deliver focused hit to occlude the cord, okay, selective occlusion or coagulation of that umbilical cord or large intrafetal vessels, okay, and these are performed as outpatient procedures under local anesthesia. So what are the techniques? So one is radiofrequency ablation, another is bipolar cord coagulation, intrafetal nasal ablation, and suture ligation. So these are the 4 methods for this monochorionic pregnancy termination, selective termination. Now we will see each one separately. So radiofrequency ablation, it is done between 15 to 27 weeks of gestation. Here what they are doing is they are using 17 gauge radiofrequency ablation needle. So it is a specialized needle, RFA needle. It is inserted percutaneously at the level of intrafetal portion of umbilical cord. And here this radiofrequency energy, it is applied at the electrodes which are situated at the tip of the needle until an average temperature of 110 degrees Celsius is achieved in all 3 electrodes. Okay, all 3 electrodes for at least 3 minutes. So 2 or 3 such cycles should be used until the total cessation of blood flow is demonstrated by the color Doppler of the cord. So this RFA, it can be used in MCDA pregnancies discordant for fetal anomaly. So one baby is anomalous, one baby is normal. In that case, this RFA is used to selective terminate that fetus. In case of severe selective growth restriction, so see MCDA pregnancies, there are so many complications are there, like twin-to-twin transfusion, selective growth restriction. So in case of severe selective growth restriction also, you can use RFA to minimize the risk to normally grown twin. Okay, but if termination is not acceptable, then you can do fetoscopic laser ablation of this anastomosis. So this RFA you can do for this multifetal reduction also in case of monochorionic twins, because you can do it at earlier gestation also. And also for ST of a cardiac twin in case of trap sequence. So see, a trap sequence, it is a cardiac twin. So it will be just a mass. Okay, so here you cannot differentiate the cord and all these things. So in these structures, so you can do it at early gestational age for cardiac twins, but at later gestational age, you cannot do this RFA for a cardiac twin. So then for that case, usually it is a laser ablation. A cardiac twin at later gestation, laser ablation is a good choice, but earlier gestation for MTR also and a cardiac twin also, you can use this RFA. Now, bipolar dithermy cord coagulation. So here, what you are going to do, you are going to take a small skin incision and with ultrasound, under ultrasound guidance, a port, a small port like laparoscopy port, you are going to insert, and it should be inserted intraamniotically. So it should go into that amniotic sac under local or regional anesthesia. Bipolar dithermy forceps, they are introduced through that port, and you are going to grasp a free loop of the umbilical cord, and the cord is fully coagulated along several points, okay, with very small use of energy like 30 to 50 watts of bipolar cord rate for up to 60 seconds per burst. And again, you have to confirm with the color Doppler flow. So when there is complete cessation of this blood flow in the umbilical cord, okay, and fetal asystole. So here for this procedure, the umbilical cord thickness should be less than 12 millimeter. So it should be done at a somewhat earlier gestation. So it is usually done between 18 to 27 weeks of gestation. Before 18 weeks, it is difficult to do. And after 27 weeks also, when the cord thickness becomes more, it is again difficult to do this cord coagulation. So ideal time for this bipolar coagulation is 18 to 27 weeks. Now intrafetal laser ablation. It is ultrasound guided laser ablation of this intra-abdominal aortopelvic vessel. So here not going to do the direct cord coagulation, but you're going to do the laser ablation of intra-abdominal aortopelvic vessels. So here you are going to use this 18 gauge needle. It is inserted in the fetal abdomen adjacent to pelvic vessel. And this laser fiber, it is advanced 1 to 2 millimeter beyond the tip of the needle. And ND arc laser is used and laser coagulation is performed at 40 beds until you found the cessation of blood flow in the iliac arteries and umbilical vein. And finally, fetal asystole occurs in around 60 minutes. So you are going to coagulate the vessels, pelvic vessels, okay? So iliac arteries and umbilical vein, and then finally the cardiac asystole will occur at 1 hour later. So the advantages of this laser ablation, it is that it can be used when a free loop of cord is not easily accessible, like it is a trap sequence. So as I told you, trap sequence, it is usually a cardiac vein is a mass of a tissue. Okay, here you cannot differentiate into different organs. So in that case, the free loop, obtaining a free loop of cord is very difficult. So here this intrafetal laser ablation is a procedure of choice for this cardiac vein. Now, suture ligation you can do after 26 weeks of gestation also. So you can do this ultrasound guided suture ligation, but it is not used routinely now. Here again, it is a laparoscopy, small port you are going to insert in the amniotic cavity, and like extracorporeal laparoscopic knotting, you are going to insert a small loop of monofilament suture through a 2 mm forceps, and it is placed under the cord, and then you are going to tie that knot by extracorporeal knot tying, okay, by pushing device, and then you will confirm by Doppler that there is a cessation of blood flow in the cord. So this is the table regarding the outcomes of this typical procedures for this monochorionic twins. So it is a bipolar bipolar dithermic cord coagulation, radio frequency ablation, laser ablation. So when this is done for anomalous baby, okay, so when you have done this and either cord coagulation, bipolar cord coagulation, or RFA for anomalous baby, so in that case usually the fetal death percentage is higher with radio frequency ablation, but finally all other outcomes, they are almost normal, similar to both these techniques, whether it is a bipolar cord coagulation or it is a radio frequency ablation. You can see here live birth rate is almost comparable, PROM percentage is comparable, overall survival it is also comparable, even median age of delivery it is around 34 to 35 weeks. So all things are comparable in case of abnormal twins. So both procedures can be used, either it is a cord coagulation or radio frequency ablation. Well, in case of trap sequence, there is not much data available regarding this laser ablation, but there is no fetal death has been reported, no neonatal death has been reported yet, okay. And finally, you can see here gestational age at delivery, it is more prolonged in case of laser ablation, okay. So laser ablation, it is a good thing in case of cardiac twins, okay. Trap sequence or cardiac twins, laser ablation is a procedure of choice, while for other things you can use either bipolar cord coagulation or radio frequency ablation depending upon the gestational age. Now in higher order pregnancies like quadruplets and above, so here if you don't do any intervention, the risk of total pregnancy loss, severe preterm birth and long-term morbidity, these are very high, okay. So here counseling should be done regarding this, multifetal reduction should be done, and it should be done regarding the embryo numbers. According to embryo numbers, you have to give the percentage to that couple, okay, while counseling. Usually these pregnancies are reduced to DCD8 twins, okay. Whenever you are using the this multifetal reduction for quadruplets and above, you are trying to reduce it to DCD8 twins. So the risk of preterm birth, it becomes similar to risk of the original DCD8 twins, okay. So the outcome is much more better when you do the multifetal reduction in case of quadruplets and above, and they are usually reduced to DCD8 twins. Now multifetal reduction in case of trichorionic triamniotic triplet. Again, see, whenever there is independent chorionicity, it is better to use this intracardiac KCL. But now see here, so basic the procedure of choice here is first trimester intracardiac KCL. It is the safest way to reduce the number of trichorionic triamniotic pregnancy. And usually they are again reduced to this DCD8 twins. Okay. So, but whenever you are counseling the pregnant woman, you have to tell her that there is some risk of miscarriage will be there when there is no intervention. So when you are compared to no intervention, some increased risk of miscarriage will be there. But then finally the preterm labor, the incidence will be reduced in this case because the pregnancy will be reduced to DCD8 and the preterm birth risk will be reduced to the DCD8 twins. Okay, and this pregnancy loss or miscarriage, it remains for several weeks because of this dead fetoplacental tissue. Now, this MFPR for dichorionic triamniotic triplets. So now this dichorionic triamniotic triplets, here the problem arises whether you want to do it, reduce it to the MCD8 twins or DCD8 twins. Okay, because there are one twin will be sharing placenta and one twin will be separate. So either you can reduce it to the MCDA or reduce it to the DCDA. So here what you can do is you can directly do the selective termination for that MCDA sac so that there will be a singleton pregnancy, or you can do the selective reduction of another pregnancy which is having separate placenta. So then it will be a MCDA twins. So now the increased risk of pregnancy loss will be there. And again, if you reduce it to the MCDA twins, the complications of all MCDA twins, they can occur to that pregnancy. But it is the safest choice because you can use this intracardiac ACL. Now, if you want to reduce it to DCDA, then you have to do the selective reduction of one fetus of this MCDA pair. So here you can use either RFA or intrafetal laser ablation. So here they will be, these triplets will be reduced to DCD8 twins. Here the risk of miscarriage will not increase, but it will carry a significant chance of inadvertent co-twin death. So which can range for 12% for RFA up to 46% for laser. Okay. So reduction of this DCTA pregnancy to DCDA pregnancy, there is increased risk of co-twin death. While if you reduce it to singleton or MCDA, so with MCDA, the problems of MCDA can arise, and with singleton also there will be some increased risk of pregnancy loss. So there are these three options you can do it reduction in case of DCTA pregnancies. Now, whether you should do this first trimester selective termination in case of DCDA twins. Okay, DCDA twins. So yes, if in case of anomaly, you can use this intracardiac KCL, and here the risk of pregnancy loss is very low, between 2.1 to 5.8%. So whenever there is one anomalous baby is there in case of DCDA twins, you can definitely use this intracardiac KCL. Now some patient wants that even that DCDA pregnancy also they want to reduce to singleton pregnancies. Okay, because this DCDA is also associated with increased risk of preterm birth, correct? Late preterm birth. So some patients they want to reduce it to singleton pregnancy also sometimes. So this MFPR of healthy DCDA into singleton, it carries reduction in late preterm birth and non-significant risk reduction of birth before 34 weeks of gestation. But then balance of benefit versus the risk of invasive procedure, it is unclear. So you have to give all the options when the patient wants this reduction from DCDA to singleton. You have to give all the risk associated and all the benefits. So what is the risk ratio and benefit ratio? You have to give it to the patient, and option should be given to the patient. But here the ethical consideration remains when you want to do this DCDA to singleton pregnancy. You got it? The difference between the selective termination for DCDA and multifetal reduction in DCDA. So yes, for selective termination, you have to do because it is an anomalous fetus. But if you want to do just MFPR for DCDA pregnancy, you have to balance this risk versus benefit ratio. Got it? So this is regarding this multifetal pregnancy reduction talk. Remember, when here the basic thing you should remember what are the procedures which are suitable for different types of reductions, and at what gestational age what procedure is recommended, and when this procedure. So here this at 32 weeks is more major thing because it can come as a question in case of twins or this thing selective anomaly. If you find after 16 weeks, then you have to terminate it at around 32 weeks and not before that. Okay, that is the major point in this talk. So I think I am clear. Any doubts?
Ma'am, in this DCDA twin, if a woman asks for selective reduction, we explain to her the risks and options. But in case she does not ask for it, still do we have to offer or not?
No, we should offer MFPR only for triplets and above. Okay.
Okay.
Already it is given in the talk. In the first only I have given you. You can see the recording again. You will understand. So triplets and
Yes.
above you have to offer. But yes, if she asks, you can give her. You should give that option. Okay, but you have to tell all the risk versus benefit ratio.
Got it.
Got it?
Got it, ma'am. Thank you.
Okay. 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 So thank you. Tomorrow we will have another talk discussion. Till then, bye.
Bye, ma'am. Thank you.
Thank you, ma'am.